All right, so then vascular bleeds and traumatic bleeds. So vascular bleeds is where you have some kind of AVM, you have some kind of what are called a diulifoid lesion. I thought I had a picture of a diulifoid, but it's like a little gopher, right? So like little sticks up, and like a little vessel under there, right? So the gastrum's on top here, right? So here's my gastric layer, got a little hole in there, and the little artery like pokes its head out and it starts bleeding as a little diulifoid lesion, right? So it's a you'll see that from time to time. And then AVMs are, of course, are genetic. That's not something we can really predict. So they'll come in with a GI bleed and they'll have the hematemesis. They'll have the same symptoms we had before for GI bleeds, right? And then we have traumatic reasons. So they have Mallory-Weiss tears or Boerhaave's. The one that's more serious is the Boerhaave's, right? Because they've actually torn through their esophagus in this case. And Mallory-Weiss, they have tearage of the esophagus, right? They've been heaving, they've been vomiting a lot, and they can cause tearing of the esophagus, right? But once you've poked through the esophagus, then now you have Boerhaave syndrome, which is an esophageal perforation, which is much, much worse. Requires a cardiothoracic surgeon to be involved to be able to repair the esophagus, right? So air can leak from the esophagus into the mediastinum because that's the space that the esophagus is in. And that air in the mediastinum can cause a pneumomediastinum. So that's just air in the mediastinum, right? And it's classically, you can see the heart outline is very, very clear because air is what on X-ray? Black, right? Blood is white. So it's black on X-ray, and should you have black stuff around your heart, you shouldn't have air around the heart, right? Your lungs are a little bit grayish because there's tissue there too. When you look at pneumothoraces, it's like pure black, but the ribs and the back muscles were there too. But we have this nice outline of the heart, and also you have on auscultation, you can hear a crunching sound. Almost sounds not like a rubbing sound like pericarditis, but you hear a crunching sound with every beat because it's like sub-Q emphysema. If you touch someone with a chest tube that's leaky, they'll have all this Rice Krispies on their skin. So you have Rice Krispies around your heart. And that sounds like it's called a Hammond's crunch. It reminds me of like Captain Crunch. But it's Hammond's crunch is where you are listening to their chest and you hear a crunching sound with every heartbeat. And how do you know it's not their lungs? You just tell them to hold the breath, and then you hear the beat of the heart, and you can look at the monitor to time it up, right? To sync it up. So yeah, so if they're vomiting all the time, they're high risk of getting Mallory-Weiss tears. And ironically, someone with ulcers who's vomiting all the time can get a Mallory-Weiss tear. And someone who has a variceal bleed could be vomiting all the time, and that can lead to a Mallory-Weiss tear as well. Worst case scenario, a Boerhaave's, where they have an esophageal rupture of some sort, right? So you got an upper GI bleed. This will start oozing. That's a Mallory-Weiss tear right there. It's going to start oozing into that stomach, and then you're vomiting from the blood from your Mallory-Weiss tear. That's your cards weren't dealt right that morning, right? So you have obviously it's going to be worsening things, and we have to figure out what it is. And it's figured out by doing an EGD, where you do an EGD to figure out what, you got a Mallory-Weiss tear there. It's really just kind of rest, right? There's nothing much they can do. They could, I guess, suture it, but there's not much else they can do with the Mallory-Weiss.
So is it a variceal that's poking up through the Mallory-Weiss tear?
No, Mallory-Weiss tears are different than this diulifoid over here, right? The diulifoid lesion is just a vascular abnormality. Now we're talking like traumas, right? So you've caused trauma to your esophagus and trauma to your stomach, right? So it's really that junction right here, this muscular junction right here, that's getting traumatized. Diulifoid lesions are something different. AVMs are something different. All right, so variceal bleeding. So this is our deadliest form of bleeding. It's only 5% of our bleeds, but it has like a 40% mortality. And we just with the initial bleed. And then if you get another bleed, you have a 60% chance of bleeding again once you had one bleed. So it's a very, very high risk situation that develops most commonly from our cirrhotic patients, right? So cirrhotic patients have portal hypertension. And where's the portal circulation? That's the whole Brita filter from our stomach and our intestines. Everything's like, I don't trust what you eat. You eat cafeteria food, you eat fish that's been out all day, so I'm going to filter that for you, right? That's what your portal circulation is designed to do. So it takes all the fats from your meals, it takes all your nutrients, it takes all the toxins as well, and then the liver is going to say, nope, stop right there. We're not going to take in C. diff today. You're done, right? Your E. coli, nope, we're going to attack you right now. You just go ahead and turn around, or we're just going to eat you over here in the corner, right? So That is, so your liver is a huge filter to make sure you don't get infections, make sure you don't get toxins. It also has other functions as well. But with cirrhosis, they start getting cirrhotic, which is not helping out, but they get scarred, right? Cirrhosis is just a fancy way of saying they get scarred. So not scared, but scarred, right? So they have scarring of their liver, and now this flow of going into the flow of going into the liver is now higher pressure system, right? And now these veins are not used to that, and they start bulging. You got bulging veins that are happening. And then they're like, you know what? I know how to fix this. I'm going to go ahead and release some vasodilators. I'm going to go ahead and vasodilate over here, right? So I say, hey, I got vasodilators I can do to fix this. The pressure's super high over here. I'm just going to lower the SVR, right? That's all I got to do. Just make it dilate, and it's going to be super big. Like, let's go from like a 2-lane highway to a 4-lane highway. This is going to be great, right? And little they know that the vasodilators they release made its way through, but nothing else. So the vasodilator is now in the system, and now you're vasodilated in the system, and now all that's, you get hypotensive, which is not good. But also the vasodilators are going to vasodilate the portal circulation, and now that's more volume to fulfill the portal circulation. So they played themselves, basically, right? So now you have all this extra volume inside your vascular space. And by the same token, you get, when you have portal hypertension, your liver doesn't work, you have ascites, and ascites puts more pressure on your circulation, and you don't produce albumin, and albumin is going to cause, it's what holds on to fluid, right? So this is going to cause a dramatic increase in the volume in the vascular space, right? So the GI bleeding is a consequence of cirrhosis and portal hypertension. And what makes it bleed right now on a Tuesday? It's not like, oh, it's Tuesday, time to bleed. That's not how varices bleed. Varices bleed when you have an infection or a surge response, right? The only reason why this is oozing right now is because it was vasodilated from prostaglandins and other acute phase reactants and inflammatory markers, TNF alpha, IL-1, all these different fancy inflammatory markers. They got released and they made them vasodilate and leaky enough to where they start bleeding profusely, because this is ready to go. It's burst at the seams, right? Ready to burst. Okay, so that's the idea behind behind portal hypertension and cirrhosis causing a GI bleed or a variceal bleed. And is cirrhosis the only reason? No, you can get schistosomiasis, right? If you swim in fresh water, I believe is where you get that parasite, and it likes to swim down your GI tract that you swallow the water from, and then it likes to crawl up your hepatic duct, and then it's going to lodge itself in the portal circulation. Or actually, it crawls up there and it lays eggs, and then the eggs then go down the portal circulation and block the flow, which is cool. All right, then you have your portal vein thrombosis can happen, like usually cancers and other masses that might cause a clot to form right there in the portal circulation. That's going to back up the traffic, right? Increase in the portal hypertension, pressure within the portal circulation. Right? So the key thing here is if they are bleeding, oftentimes, oh, the blood pressure is 80, let's give them fluids. Well, they're already burst at the seams. Why are we giving fluids? That doesn't make any sense at all, right? So giving IV fluids will make them bleed more. You give FFP, and FFP is about 400 cc's of fluids. It's like, oh, they're a cirrhotic patient, they're high risk for bleeding, let's give FFP. Well, you're going to make them bleed more, right, if you do that. And same thing if you give PRBCs, right? So you give PRBCs, that is another 300 cc's of volume. That's also going to worsen their outcomes. So what the heck do I do, right? So how do you fix this? Thoughts and prayers and a good GI doctor that knows how to use an EGD, right? Because a scope is the only answer, right? You can temporize it when you give 1 unit, 2 units of packed RBCs. Definitely not FFP and definitely not IV fluids, unless like there's an anticoagulant, right, that they're on, then you can give the reversal agent for that, right? But PRBCs, 1-2 units, where that might be the limit of what you should do. It really vasopressors is where it's at. That's to support their blood pressure. Blood pressure is low. Giving fluids is going to be the wrong answer, right? So the answer is to scope, right? So that is the EGD is what we need to do to get them fixed, right? We need to go in there and fix that variceal bleed.
So you said the variceal, esophageal varices can only bleed if they have some kind of like initiating factor, like an infection, they can't just start bleeding because of how much.
They don't
pressure
just
there is?
ooze. I mean, if they do, it's rare, very rare. It's what's happening is they have some kind of infection, right? And they did research and they said the reason why people bleed is because of infection. Someone made that connection. I don't think they swallowed a test tube of the stuff, but what they did is they started giving ceftriaxone to cirrhotic patients when they bleed, and they say, well, lo and behold, the mortality is so low now. Right, so you give antibiotics and they get fixed. The GI bleed doesn't go away. We got to fix the piece that bled because it was ready to go, and then it got the infection. Really, just could push it over the edge.
And it's still typically H. pylori in those cirrhosis patients.
No, H. pylori is not related to cirrhosis. H. pylori is related to peptic ulcer disease. Right, H. pylori. Yes, you give antibiotics for H. pylori, and you give antibiotics for cirrhosis. Right, but you're giving antibiotics that are in the GI tract. Right. Because that's commonly what happens in cirrhotics is they have spontaneous bacterial peritonitis that develops in the acidic fluid, and that will then translate and cause an infection, right? So that then puts you at risk for a body-wide inflammation, and the body-wide inflammation causes you to GI bleed or cause you to have hepatic encephalopathy because your blood-brain barrier is also leaky, and you're going to leak through that as well. And the ammonia that's being produced by your GI gut, right? Usually it's being produced by your gut, but also your liver is supposed to be managing the ammonia, converting it into BUN, but it can't because it's broken. It's cirrhotic, right? So the ammonia builds up, and people are walking around with an ammonia of 250 all the time. But why is this person with 250 fine and this person not? This person over here has an infection, right? So that's why giving antibiotics would help. Okay, so that kind of relates to our patients that with cirrhosis have high ammonias, as we know, and if an EGD does not work, we have to, we are going to try to do EGD. If that doesn't work, we need to do what's called a TIPS procedure. All right, so it's called a transjugular intrahepatic portosystemic shunt. So all you're doing is putting a shunt transhepatically, right, through the liver. You just go right through the liver, just like our ventriculostomies. You go right through the brain, through childhood memories. You're going to go right through the liver, through the Flintstone vitamin you ate as a kid. So TIPS procedures, so they are going to be used for variceal bleeding. So when we have all of this high pressure in the portal circulation right here, all this huge portal circulation, beefy vessels, they're all swollen right there. Well, we can provide them an outlet, right? So that's really, really high pressure, and it's higher than the CVP, right? CVP is what, about 8 to 12 on a really good day, or about 0 to 8, right? 4 to 8, somewhere in there, depending on which source you look at. But portal hypertension is defined as greater than 18. Right, so greater than 18 is usually portal hypertension. So that means that we need to, reroute that blood somewhere. So everything goes high to low. So someone got the bright idea is like, let me just put a shunt in it, right? So they put a shunt in it, and then now everything's go from point A to point B, right? So that's going to be a transjugular. So they go through the jugular, and they then do a transhepatic or intrahepatic portosystemic shunt, going from the portal circulation to the systemic circulation, right? So it's a TIPS procedure. So it's going to fix the portal hypertension, but it's going to worsen hepatic encephalopathy. So hepatic encephalopathy is ammonia buildup that's going to go to the brain, right? And it goes to the brain when you have an infectious process. But in your GI tract, your bacteria produce ammonia, and the ammonia is going to then, usually gets filtered by the liver, right? Or it packages together with other ammonia and some CO2 molecules and makes BUN, but your liver's broken. So that ammonia is, A, your liver's broken, but also B, all the ammonia is going from point A to point B. It's going right into circulation, so there's no filter at all. Right, so it's very easy to get hepatic encephalopathy with these patients. Okay, so we bypass the problem child, but we have hyperammonemia, right? So you have too much ammonia in your blood. Okay, and again, it's a last-ditch effort. Usually, it's a once someone has a variceal bleed, and A, you can't fix it with an EGD, or B, they have failed EGDs, they had like multiple variceal bleeds, and now it's time for a TIPS, right? So refractory ascites, they got multiple varices going on, right? They have severe portal hypertension. This is a time where they can go ahead and bypass the liver if possible. Okay, going back to the EGDs, what do? They band them. So they go into the esophagus and they literally scoop it up with a little vacuum and they put a rubber band on it, and it just kind of pinches off the vessel. And we'll talk more about that when we talk about the EGD things we do for both peptic ulcer disease and for variceal bleeds, right? So they can put some glue on it. If they're in the gastrum, they can put some glue to kind of patch it up sometimes. But really the best thing is to do banding. That's usually the go-to thing that we do. There's another option if they have a fistula of some sort, something that's causing a lot of pressure to bypass and cause like hepatic encephalopathy. We can do what's called a transvenous obliteration of these vessels here, and that will help alleviate some of the portal hypertension as well. Okay, so what else can we do? So again, the TIPS is more of a rescue therapy, right? They have refractory rebleeding, and we have all this variceal problems because of all this cirrhotic liver and this increased pressure in the system, and the vasodilators are being released to hopefully fix it, but it actually worsened the portal hypertension, worsened the volume amount in there. Okay, and back to those are the indications, but what about the contraindications? Well, we're putting a lot of fluid from point A to point B, so that heart needs to be able to tolerate it. And if they have sepsis, that's going to make the hepatic encephalopathy a lot worse, right? So that's going to be a problem. Pulmonary hypertension, right heart failure, that's a lot of extra volume on that right system now, right? We're going to a lot of pressures feeding into the right side. Okay, coagulopathy, yeah, if they're at the point where their liver is not making any kind of coag factors, putting a huge, huge shunt through it is going to be a big bleeding episode as well. Okay, so these are the ideas behind what we can do to kind of patch it, right? Literally with banding, we can literally glue it together, or we can do a shunt, where we're shunting away all this extra volume away from the portal circulation, which is high in pressure.